Good morning. My name is Dr. Nandita MANJUNATH, and the title of my presentation is Rein the Haptics, where we talk about the innovative approaches to overcome IOL implantation setbacks in cataract surgery. Phacoemulsification is one of the modern cataract surgeries, and we use foldable implantable IOLs like trifocal, multifocal, and toric and monofocal IOLs, to name a few. Now, these surgeries may be met with certain setbacks, for example, the IOL implantation setbacks. These can be broadly classified as optic or haptic damage before, during, or after implantation of the IOL, and it may sometimes lead to compromised visual acuity due to a different IOL power being implanted, or the patient may be left aphakic. Further diversifying the causes, the optic or haptic damage before implantation can be due to bent or missing haptics, or broken or optic or a haptic, and sometimes due to sterility issues. During implantation, it can be due to a bent, broken, or stuck optic or haptic. And after implantation of the IOL, it can be due to an inadequate capsular support due to zonular dialysis or posterior capsule rupture. We aim to identify the complexities leading to IOL implantation setbacks and determine its contributing factors, and also to recognize the surgical technique for IOL explantation if used, and to compare the IOL implantation setbacks before and after implementation of certain preventive strategies. This was a retrospective study done in a duration of 1.5 years. We included the phacoemulsification surgery cases that underwent IOL-related complications or setbacks, and we excluded all the uneventful phaco surgeries. 29,630 phaco surgeries were analyzed using the surgery notes and the lens reporting form for the various reasons of the IOL implantation setbacks. This is the example of the lens reporting form that we use at our hospital. From this, we can know the exact step and the exact cause for the IOL implantation setback and the technique of explantation. We collected data regarding cause for the IOL implantation setback, the type of the IOL, details of IOL replacement if any, method of IOL explantation, and the final visual outcome on postoperative day 30. Of the 29,630 phaco surgeries, 155 cases had IOL implantation setbacks, which roughly amounts to 0.52%. The avoidable setbacks were optic or haptic damage before or during IOL implantation, and unavoidable setbacks were due to sterility issues and complications. About 82.4% of the IOL that underwent setbacks were monofocal foldable, whereas 9.2% were EDOF lenses, 4.6% were advanced monofocal, and 3.9% were multifocal lenses. 17% of the cases used toric IOL power. Majority were hydrophobic lenses, and 27% were hydrophilic lenses. Of the cases that underwent setbacks, majority, around 40%, were identified before implantation of the IOL, 28% were during implantation, 17% were sterility due to sterility issues, 9% were due to complications, and 6% were after implantation of the IOL. 71% were preloaded lenses, whereas 29% were manually injected. Of the cases that underwent IOL implantation setbacks, 90% needed an IOL replacement, of which 60% were implanted with the same power lens, and 10% of the cases did not require an IOL replacement. In 15% cases, a 3-piece lens was placed in the sulcus. Of the cases that needed IOL explantation, in 26 cases the section was extended, whereas in 20 cases the section was extended and the IOL was cut and removed. In 15 cases, only the IOL was cut and there was no section extension. Sorry. On assessing visual acuity on POD 30, we found that 80% of the cases had visual acuity between 6.6 to 6.9, and 15% had visual acuity from 6.12 to 6.60. We implemented certain preventive strategies like placing visual cues in the operating theater to enhance guidance during the IOL implantation, regular training of the staff of both the paramedics and the surgeon for proper IOL loading techniques. Injecting the IOL under a IOL magnifier improved the precision significantly. Pre-warming of certain lenses increased the optimal lens flexibility. We implemented these in the month of March 2024, and we analyzed data from January 2023 to June 2024. And we found that the average, before implementation, the average phaco per day was 76, average implantation setback per day was 0.94, And after implementation, even though the average phaco of day was increased to 93, the average implantation setback was reduced significantly to 0.42. In conclusion, I would like to state that proper documentation of these setbacks is of utmost importance. Implementation of preventive strategies reduce the rate. Regular training of staff is important, and for the surgeon to always inspect under the microscope before implantations. Thank you.
One or two questions. What were the sterility issues? I mean, how did you know that it was not sterile? All lenses that we pick up are sterile. How did you classify them into sterility?
So,
how could you even think of putting an unsterile lens?
So sometimes the lens slipped, and it was of course not used, but the lens slipped during implantation.
So that you didn't implant, no?
No, sir, we didn't.
If it fell on the drape?
Yes, sir.
When it fell out.
Or
Yes.
fell out in a sterile area, or even an unsterile area. Supposing it fell on a sterile drape, you consider it sterile or unsterile?
So we considered it as unsterile.
Okay. Other thing is, how did you pre-warm a lens? I've noticed that the haptics get stuck when you keep the lens in the operation theatre, which is very cold. And how did you pre-warm these lenses?
So we used a pre-warmer.
What is a pre-warmer? We just keep it over the autoclave or something like that.
So we
and
use
on
a
the
warmer.
surface of the autoclave for some times, because it becomes a little warmer in our winters, and especially if the air conditioning is very, very effective. So how did you pre-warm these lenses?
So we use this IOL warmer where the lens can be placed
There
here.
is something called an IOL warmer.
Yes. So this is the IOL warmer where we place the lens here, sir. So it's pre-warmed before the surgery.
And what is the difference between preloaded lenses and the lenses that you implanted, which had to be put into the case?
So certain lenses are already preloaded before.
No, I know that, but was there
Yes, sir.
difference between the breakage of the preloaded lenses versus breakage of the
Preloaded lenses showed higher complications, she said.
Yeah, I didn't. But that is usually not so, because
No, preloaded lenses are always trouble, sir. We also don't
I
use
don't think
preloaded.
so.
No, invariably, while trying to inject, we need to reload, or we need to...
Preloaded can't be reloaded. Which lenses are we? I mean, we use preloaded lenses mostly from Hoya, which are with one of the best injectors.
Hoya we have not used,
best
sir,
injectors
but
in the
preloaded lenses coming with the other companies not so good.
Clarion nowadays, which with the preloaded, is also very good.
Have you experience with Indian preloaded lenses?
Indian preloaded, exactly.
They
They are not so effective.
Because preloaded lenses are something that we look forward to now, and they go especially.
That is why we tried in the Indian companies, and they are not so good.
Indian companies?
Yes, sir.
Yes. I never wanted to say, but
You have to say that.
it's about the discussion. Yeah, see, 70% of the loaded lenses they had problem. Only 29% of the lenses to be loaded had problem. Which is a reverse to our experience.
Manually.
But that is
Very true.
Manually injected loading is 71%.
yeah, ma'am.
No, manually injected 23%.
How many lenses are loaded by
71 to 71%.
That is preloaded. Blue is preloaded.
Preloaded.
We also face
Sir,
the
it's a
same
surgeon preference. Some lens, it depends on the surgeon. Some surgeons do it by themselves, and some it's loaded by the surgical assistant.
Very good. Loaded by the assistant, they were more prone to these problems.
So we didn't find significant.
No, I'm sure in her study all were loaded by the staff. Correct? All the cases were loaded by
No,
the
ma'am.
staff in your
Some
study?
were also loaded by the surgeons
Surgeons
themselves.
also.
Yes,
But
ma'am.
you didn't differentiate that.
Yes, ma'am. We didn't differentiate.
But anyway, it's a very good case.
Thank you, sir.